Can we do that? Sorry. To say no. What do you have tomorrow? Work on our own. I'm having down for 5. Some in Brooklyn. Yeah. Big down in Brooklyn. Yeah.
Wow.
The only things like beach.
What about the? Yeah, yes. Yeah. Also, it is. Then we won't see.
I don't know. I don't get it. I don't get it.
Pushing into the door. It's okay, I do that every time. Thanks, Joe. I know, I feel like people think I'm yeah, no, you call me. She got
Good morning. Good morning. Happy Monday. Gosh, it's so good to see you after last week. Everyone should feel so proud of themselves. Good job. So I am still, well, start with prayer, shall we? And then we'll jump into all that. Okay. In the name of Father, Son, Holy Spirit, amen. Lord, for this day. Oh, goodness. Thank you for bringing us here safely to this place. Say special prayers. This is our last week before break that we can work hard. Study hard and just get through this midterm week. And then just prayers for protection as everyone travels or wherever they may be doing over break. Everyone is safe and healthy. Comes back to us safely, rejuvenated. We say a special prayer for Mr. Semperman, with a very, very generous donor to our college. So we just bring him to heart and mind and bring him in prayer to you and for his family and all his friends and everyone who's mourning his loss. Thank you for the gift of him and his generous heart. Yeah, help us be grateful for all our many gifts that you've given us. Amen. Okay, so that in mind, Mr. Semperman, what building are we in? Semperman. Okay, so this is the gentleman who has been so generous to us. He was here in the 50s, graduated with a degree in mathematics, had probably 5 or 6 minors, including history, literature, physics. Can't remember the other 2. But he was a learned man, a curious man, right? He went on to get his master's in physics from the University of Nebraska, and then his MBA from the University of Washington. He was very successful in business, so his mathematics and physics came in to play, and he had businesses that were very successful, and he never forgot Carroll College. He's a Butte man, so he never forgot where he came from. He's given so much to us. So I want us to write a little note of No, it's not. It's sympathy, but gratitude for him to send to his family. So I want to give you a couple minutes to be thinking about that, because I'm going to be sending these little sheets of paper around so that you can fill them in nicely. And just kind of think of words that you would want to hear if that was your loved one, and how we appreciate his generosity. Not only the space that we have here, you guys, are a remodel upstairs. He was a generous donor to that and before that. And then the library space that you have, right? And every year he would give scholarships to mathematics, engineering, and guess who else? Nursing. He had a soft spot for us, which was so kind. And it was a generous scholarship, $10,000 a year, starting as juniors. And repeatable senior year. So $20,000. And no matter how many people applied from the nursing department, they would always seek out feedback on who they should give the scholarship to. So we would go down and visit with he and his wife, and they never turned anyone down. So like some years it was, I don't know, 4, I think was the lowest. I think the biggest number was 10 one year for nursing alone. I'm like, holy moly. Holy moly. So that not only impacts us and the individual student, but think of that ripple effect. All those people that they will care for are impacted by that gift. So be thinking of what you want to say. And exam. So good job getting through the exam. Is it too early to get feedback? Is it still raw? Do you want to get your grades first before you tell me what you thought of it? I'm still working on it. I am trying to get them done. I mean, so far it looks okay, right? Can't say it looks awesome, but I can't say it looks horrible. It looks good. It looks good. You can lose a lot of points. Really, 75 points, right? And your skill demo is 25, so all that's up to 100. So I'm gonna plug away on those today. Plug away on those after lab tomorrow. I really want to get them back to you before Wednesday. So good job getting through that. You can see some common trends perhaps. Like this. Does everybody remember what that is? Now you do?
Yeah.
Now forever will you? Saline, administer saline. And why do we do that? Yeah, get the medication to your patient, thank you. And what if I have like 3 different things to give? Like IV push, or then an antibiotic, and then another IV push. Precipitate can form, right? Incompatibility. So you're plugging that into them, making sure they get the medication actually. And then clear the line so that it's ready for the next medication. Yeah, so you'll remember saline, administer saline, right? Yeah, we'll talk about yeah, PCA. PCA, you guys found the issue on, we had a couple problems, right? So yeah, the pump one, you actually have to like get in there and look at it. I think only 2 people actually like push the buttons to get in to see it. So then that would impact how you were able to answer that question. Sure. But other than that, it's good. Really. So good job. Good job. If you didn't pass your skill demo and you haven't reached out, just please do that so we can get that taken care of this week before you head off to. Okay. Question? Okay. The notes, that's our sent from my notes. And Wednesday is Ash Wednesday. Start of Lent. And there's mass on campus at 0700. Which is awesome. Well, we're here. So I certainly not gonna say don't go to mass. You can come, but please come because we're gonna have a quiz. So I will put the quiz at the end of the time period. Okay, so. Know how much I love my kidneys, so want us to know our kidneys, so I'm gonna be testing you on your kidneys. Okay, so please, if you go to 7 a.m. mass, zip on over afterwards. You can still. There's also one at 4, but that might not work in your schedules. So, yeah. I think that's it. Any questions? You got lab this week, you got clinical this week. You gotta pack up. That's so fun. Okay, any questions or things I should be talking about? Very good. Okay. Oh. All right, let's jump into renal. Remember, spirit organ. The kidney. That's what I would do. Heart, kidney. Wish it was the brain, but I love my kidney. All right. So tell me all the beautiful things our kidneys do for us.
Remove waste.
Awesome. Remove waste. If they didn't do this, what would happen? What would happen? Is it?
Like toxicity.
Yeah, toxicity would build up in our blood and we would die. So kind of important, right? Okay. So if we understand physiology, to understand the signs and symptoms, you might see when things aren't working well. Okay, so these little pieces of paper, these right notes of sympathy, condolence, and gratitude to Mr. Zimmerman's family. This passed on down, we ran out of space. We use the backside, but I got another space. Okay, so we remove waste. If you cannot do that, we will not survive long. What else?
Put an electrolyte balance.
There we go. Fluid and electrolytes. What happened? If my kidneys cannot do that. Yeah, lots of things, right? That whole chemistry panel that we look at. So much of that is responsible of the responsibility of the kidneys, right? And then urine dilution versus urine concentration. So this is so critical. Oh my gosh, we can have low sodium happening, we can have high potassium happening. And with that, we can have arrhythmias happening. We'll talk about cardiac coming up, but that's bad business. You can't regulate those. Awesome, keep going.
Hormone function.
Yeah, like.
It helps with a lot of different ones. Like secreting renin for blood pressure.
There you go.
EPO. Activates vitamin D.
Yes. What is that?
EPO.
Yeah. So let's break those down. Renin-angiotensin system, aldosterone system helps us what? Regulate blood pressure, right? That's key. Key. Sometimes high blood pressure causes renal damage. And then turn renal damage will cause hypertension. We have this very cyclical nature. It's not going to be beneficial for us if our kidneys are not functioning. This is one of the reasons we are aggressive with hypertension management. Known as the silent killer, right? Why do we say that? We say hypertension is the silent killer.
Those are two of the symptoms that you see with hypertension.
Right, yeah, absolutely. You don't really have symptoms until maybe it's a very, very extreme. So we can have people stroke. They don't know they have high blood pressure until you check it. Right, that's why it's important for people to get their blood pressure checked on a regular basis, because you cannot feel this. But meanwhile, while this is happening, blood flow to your kidneys is being affected. Right, so that can cause this cyclical pattern of not being able to regulate blood pressure well. Awesome. What's this vitamin D business? What's vitamin D needed for? Calcium, right? So if we did not have our kidneys producing active form of calcium D or vitamin D, it cannot, our GI system cannot absorb calcium. You don't have it. Right, that can lead to all sorts of things, osteoporosis, fractures. That is it. All right, what's EPO? Retro. Something in there, so not my erythropoietin helps us what? Yeah, stimulates the bone marrow, that hey, bones. Bone people produce RBCs. Without that, we have anemia. Right, anything else we forget? Excretion of waste, regulation of fluid and electrolytes, ooh. Regulation of blood pressure, secretion of erythropoietin, and activation of vitamin D. One more thing. You all know how to interpret now.
That's based on.
Good job. Acid, base, balance. So this is where our metabolic is coming into play. That's what we're talking about. If our kidneys aren't functioning, then they're not able to absorb hydrogen ions. They're not able to absorb bicarb and regulate that balance. So you will see impacts in all areas. So when we're talking about chronic kidney disease on Wednesday, what kind of things do you think your patients will present with? Hypertension? Yes, good. Keep going. Anemia? Yes. Along with that, fatigue. You know what people look like when they're on dialysis? They look kind of gray. Coloring is like, oh my gosh. Look at this. What else? And the fact that they're having their blood removed from their body 3 times a week, put back in. They cannot feel good. We want to prevent that by all costs.
Really dark.
Yeah, very concentrated and scant amounts a lot of times, right? Yeah, good. Yeah. And it can be edematous. It can be scratchy because of the toxins that their kidneys cannot get rid of them. See them like itchy, arthritis. So not a fun state not a good place to be when our kidneys are not functioning well. So we want to be on top of this kind of thing, hypertension. We want to be cautious with nephrotoxic medication. We want to be promoting good hydration. And when we talk about diabetes, glucose control. Because we know if we do not have good glucose control over a long period of time, it affects the kidney's ability to filter. And so the road to kidney failure is before people with diabetes. Okay, so glucose management, hypertension management, watch your nephrotoxic meds. Good. Yeah, prostaglandins and bradykinin is what is responsible for affecting blood pressure at the glomerulus and the afferent arterioles, as well as out in the systemic vasculature. Okay, so that would be going along with renin and aldosterone. Okay, they're doing it in different ways, but regulating blood pressure is the end goal. Okay, let's go through some cases here. Jump. Stop that is the end goal. How do we stop that? Cannot stand that. Okay. You have to listen to that. I know you hear it differently than I can hear it, but still it sounds weird. Okay. So I just turned it down. So seriously, you have to tell me how to stop it. This one go? Ooh. If I do that, will they be able to hear you? Okay. Okay, all right, so we just talked through this. What do our kidneys do? They remove waste, acid-base balance, gluten electrolyte regulation, hormone function. I will ask questions on all these things, people. Because if you understand this, you can understand anything that you might be seeing when your kidneys are not working. Okay, so common diagnostics for assessing the renal system. Tell me about the chemistry panel. We can get BUN and creatinine. The normals for BUN and creatinine. BUN, let's start there.
8 to 21.
8 to 21. And then creatinine. Two is what I want you to remember. Can be up to 1.4. I want you to start paying attention to 1.2. UA, what does that tell us? Sorts of little things. We have a pee in a cup, and we can check. What?
Tell us if there's like protein or glucose
Right.
or like bacteria, things like that in here.
Good. Should any of that be present that you just mentioned? Protein? Should we see protein?
No.
No, not really. When we do, we're like, what's happening with our kidneys? Maybe our glomerulus. White blood cells. They be there. Pus.
Yeah.
Blood. No, none of that should be there, right? Technically, urine is sterile. So if you're ever in a dire situation, dire being the keyword, and you have no water source, you have to be a little desperate. You could drink your pee. Dire situations. Not sure how long they can do that, but for the short term. They stop making pee, I guess, right? Okay, so nothing should really be in our urine. And when we know that there's something happening, we see glucose spilling over into our urine, it means our glucose levels are greater than 1. 220. So when our blood sugar, if I took someone's little finger stick and I checked it and it was 250, if I took their urine specimen, I should see glucose in that as well. It's not a good sign. But that's something that we take note of when we're trying to work up someone for diabetes. Their pee smells sweet. Their breath smells sweet. They have too much glucose, right? So when it's above 220, we start seeing it spill over into the urine. Okay, awesome. What is this 24-hour creatinine clearance? Just a guess, but I think it's where we collect urine for 24 hours and see how much creatinine is cleared during that time. I've asked you this question before, and I will ask you again. How do we do a 24-hour urine? And you're whispering and yeah. Okay,
Just like a jug that you discard first.
good, so you have them pee, that's gonna start her off and that marks your time, but we don't put that in the jug, that goes down the toilet. Good, yes, awesome, so we need to make sure that everyone knows that this is happening. The jug has to be kept cold, so oftentimes it's in a bucket of ice right by the bedside, so that you don't forget, it's right there, that you can add all the urine. Right, whether they're using the bedside commode, urinal, yeah.
If you have to start over because they, you didn't catch it, does that one count as a discard or do you discard the next?
Oh, that's a good question. I think that would count as your discard. So you're like, okay. Bad news is we gotta start over. Good news is we're started. You know, like we're doing it. We're just changing our time. Yeah, good. Never thought about this. All right, ultrasound. Have you seen ultrasounds done? Yeah, in OB. It's the same thing. We're just looking at kidneys or we're looking at babes. Okay. So ultrasound has a cold little gel. Tell your patients they're gonna have, it's gonna be cold. And then we can visualize bladder, ureters, and kidneys. Kidneys a little bit trickier to get in that deep, but can be done. If I was gonna have a bladder ultrasound done, what is key information you have to tell your patient?
Aren't you supposed to like drink so much water before you can't pee?
And don't pee.
When you start with a full bladder.
Right, because we want it fully loaded is all I can think about right now, fully full with urine. So I have them drink a lot and then say, don't pee, and then we're pressing on their bladder. So it's a little bit uncomfortable. And they're like, no, I have not peed. And you're like, I know, you did great. We're almost done. Okay. All right, abdominal X-ray KUB, what do you think that stands for? Yeah, all right, yeah, kidney, ureter, bladder. So it's an X-ray of that area. CT, MRI, sometimes needed. Tell me about IV pylography. Right, so contrast is given, good, since it's IV, it is intravenous, right? Yeah, so we are giving contrast IV, so what am I checking before I ever give contrast? This. Because if it's already at 1.2, that can be nephrotoxic. That's why I want you to be checking chemistry panels, that's your job. Protecting your patients, right? So then we give them this medication, checking allergies as well. I heard that, so good job. And then they'll go in for like an X-ray and hope it illuminates better. Or a CT. Cystoscopy, what's that? Anytime you see the word cyst, the beginning of that S or CYST, cystitis, we're talking about bladder. So we're taking a little camera. Has anybody seen an upper endoscopy be done? Or even a colonoscopy? This is the same principle. It's a camera, but it's going through the urethra into the bladder. Why would I want to do that? Open it out, check it out. Looking for tumors. Okay, and then kidney biopsy. Going in and taking a sample of the kidney tissue itself. Awesome. Okay, you know I love my diagnostics and my terminology. Okay, so let's roll through these. Oliguria is okay. Oliguria and anuria. We often mistake things. So help me help you figure out how to differentiate between the two. What is this official definition? Less than 30 miles per hour. Awesome. Times 2 hours. That's usually what we say. And basically it is less than 100 to 400 mLs in a 24-hour period. That's the official definition. Anuria, unofficially we say no urine output, but officially it is no
5.
50.
Is that right?
Right. Okay, so I know that is something. So you're like, well, it is something. But think of the medicine cups up in the lab. Yeah, they're like that big. How much does that weigh? It's 1 ounce. Don't hurt me. Tell me how many mLs that is. 30. 30. Oh my God, good job. Okay, so that's 30. So essentially it's less than 2 of those in 24 hours. Is that essentially no urine output? Because how much really should we be putting out? Depending upon how much we're drinking, medications, activity, that kind of stuff. Fever. About 1.5 liters to 2 liters. So that's basically none. Okay, so if I put this on a test, which I'm going to put it on a test, you will know what the difference is between those. Okay. And more importantly, use it correctly in your documentation and assessment of your patients. So don't say they're anuric if they put out 300 in a 24-hour period. Say they're anuric if they put out 20 in the whole 24 hours. Okay, so hematuria or hematuria, blood, right? Blood in the urine. Should blood be in the urine? No, that's an unexpected finding. Is it always visible? Like if I took a specimen and was like, oh, it looks yellow, sure, there's no blood in there. There can be blood that we cannot see. But sometimes it is frank red blood. That's what you're seeing, is just blood. So know that it can run the gamut, right? Sometimes visible, sometimes invisible. What's pyuria? Sort of Latin term, that means white blood cells present in the urine. BUN and creatinine, you know that. GFR, tell me about that. GFR. Glomerular. Go ahead.
Granular filtration.
Good job. And what's normal? 125 mLs per
Minute.
Is that what it is?
I have no idea.
Yes. High five, we did it together. Good job. 125 mLs per minute. Woo, that's normal. That's normal. So we're gonna track that, and as it declines, we kind of grade it. You know, for like acute kidney injury and chronic kidney injury. We'll talk about on Wednesday. But isn't this amazing, you guys? The kidneys receive 25% of the total cardiac output. So the cardiac output is how much the left ventricle is pushing out to the body. Every beat of the heart, 25% of that blood is going to the kidneys. So think of the aorta. Coming off the aorta are these beautiful renal arteries, and they're just like pumping that blood to that. So huge amounts of blood going to the kidneys, which is good because that's what it's filtering. And then that averages 1,200 milliliters per minute. Glomerular filtration, 125. How much filtrate do we actually produce in a day? If our kidneys were not able to absorb water back into our system. 180 liters. Think about how edematous we would be. Would we even be alive? No, because our sodium would be in the toilet and die before any that. So that's what's happening when our kidneys are not functioning, right? So that water balance right there, 180 liters. When our body absorbs back into our lives. That's amazing. Good job, kidneys. High five. Right, take care of your kidneys. Okay, nephron, can you tell me what that is? The functional unit of the kidney, right? And how many do we have?
Yeah.
Billions.
Billions.
Billions in each kidney. Isn't that crazy? It's amazing. So they're the working unit of the kidney. You know that. Cystitis is a term we use for inflammation of the bladder. Urethritis, inflammation of the urethra. And pyelonephritis. What is that? Inflammation of the kidney. So pylorography, pyelonephritis, kidney. Case study number 1. 7-year-old female presents to the PCP with her mother. The mother states that she noticed her daughter's face and eyes appear puffy, especially in the morning when she wakes up, and that her appetite has been poor and decreased energy. Daughter has no past medical history except for ear infections when she was 2 and strep throat a few weeks ago. She's up to date on her immunizations, vitals are stable, her blood pressure is elevated. What condition do you suspect? And why?
The acute post-strep glomerulonephritis.
Good job. Good job. So glomerulonephritis and specifically post-strep, right? So group A, acute glomerulonephritis. So we're talking about the glomerulus itself being impacted. That's where it's first like filtering our blood. So when that happens, we have decreased GFR and increased permeability to larger proteins. So that's where I would start seeing protein in my urine. Be like, that's unusual. I wonder what's happening. I might also see blood in my urine. I might also see white blood cells, which is called pyuria. I might have oliguria. I may have an increase of BUN and creatinine. Those things don't really help us figure out what's happening here because a lot of these conditions will have those same things. But what are the two distinguishing things about, well, let's say three distinguishing things about this type of glomerulonephritis?
The periorbital edema.
Good, so that edema, that's unusual. That is specific to this condition. Okay, so I would star and highlight that. Good job. Give me another thing. So how did you know that it was strep?
Because it says she had strep throat a few weeks ago.
Right, so this is associated with that strep. Remember, strep in and of itself is not that serious. Except if we don't treat it, it can cause this. So this is serious. It's going to cause us to have a kidney replacement or on dialysis. Okay. So thinking back, and sometimes it's weeks, not just maybe last week, 2 weeks, it can be 3 or 4 weeks. So sometimes parents don't even remember that the kid had a sore throat. All right, so that would be number 2. So that puffiness around the eyes, a recent strep infection, and high blood pressure, hypertension. Is hypertension ever normal in a, where is that? In a child? This is a 7-year-old. No. Okay, so I would start at hypertension, puffy eyes, and a recent strep infection. So what do we do to treat this? Oops, sorry, what diagnostics would we use? UA, good.
CBC.
CBC, check for that. Elevated white blood cell count, good. Chemistry panel, check our BUN and creatinine, electrolyte levels. Let's see. Throat culture, sometimes that's negative. The anti-trepsilin ASO titer is what's going to tell us that they had a recent infection. Or the throat culture is not picking up on the cells themselves. The ASO titer would. So what do we do? This is talking me through that. You can take a look at that. We see in big bold periorbital edema and mild severe hypertension. We're talking about the glomerulus being affected, right? All right, so what are we going to do about it? These nursing diagnoses would be impaired urinary elimination, fluid volume overload, that's what you're seeing in the puffiness and the edema, readiness for enhanced learning. So we're going to put them on strict diagnose, daily weights, which is the best way to determine someone's fluid status. Monitor their vital signs, measure abdominal girth or extremities. Why would I do that?
The kidneys really inflaming, it's getting bigger.
I want you to think about that for the PKD that we're going to talk about, because that's key. This is more related to the fluid. So the edema that we're seeing here, we can see here, which is called ascites. So it can be diffuse. Okay, good. Monitor skin breakdown, monitor for neurostatus, seizure precautions because of what electrolyte. Sodium, always think sodium. Ensure adequate nutrition, restrict sodium, because sodium just helps us retain. We can treat for penicillin if there's an active strep infection. We have to treat the hypertension. I'll put these little guys on a low sodium diet. And plasmapheresis. Needed. How do we know if it's effective, like our nursing care is effective? Blood pressure vaginal, no periorbital edema, renal function is within normal. That's a good. Awesome. Here in nurse, what would be the first indication that acute glomerulonephritis was improving? Oh, what would be the nurse's best response? Go S.
Okay.
Okay, good enough. Blood pressure will stabilize. Right? Will your child have more energy? Yeah. Urine will be free of protein? Yeah. Urine output will increase? Yeah. These will be all good signs, right? Yeah. Awesome. One more. A nurse is planning care of a patient with acute glomerulonephritis, which is the following intervention should the nurse include in the plan? You think you can get rid of? Wait, week. So get rid of that one. Does ambulation have anything to do with what we're talking about? So get rid of that one. And now we're down to administer antibiotics and encourage increased fluid intake. Maybe think of what is the underlying cause here? We have an active infection, we would definitely be treating with antibiotics. Okay, number 2. Who wants to read the piece today? Miss Sammy?
36-year-old male presents to urgent care with,
Complaints of, sorry.
of back pain and increased urination. Initial thoughts.
Initial thoughts. So here they come in, 36-year-old back pain, increased urination. Questions that come to mind, thoughts that come to mind, things you're gonna ask them, things you're gonna clarify.
When did it start?
When did it start? Thank you very much. When did it start? Awesome. Is this just within the last day or has this been going on for a couple weeks? Good. What does increased urination mean? Does that mean the volume or does that mean frequency? I want to know that. Anything else?
Does it hurt when you pee?
Yeah, does it hurt when you pee? We call that dysuria. Awesome. Has your intake changed? Yeah.
I mean, like, what is there to look like?
Yes, good, good. Is it coat colored or is it clear? Somewhere in between, right? Yeah, awesome. Medications? Family history? He is found to be hypertensive, which is new. Palpation reveals bilateral enlarged kidneys. Increased abdominal girth. Osteovertebral tenderness. What's that? When you punch someone in the kidney, does it hurt? Okay, we're not really punching anybody in the kidney. Does that hurt? And they're like, yeah, like a guarded response, right? Not punching anyone, just to be clear, we're not punching anyone. No. UA shows hematuria. So we have blood in the urine. Okay, what do you think this may be? That's right here, family history of PKD. So I think this could be PKD. How are you going to distinguish this from something else? Pain in the kidneys, that can be a kidney infection as well, so that might be a little bit hard, but good job narrowing it down to those 2.
Enlarged kidneys?
Enlarged kidneys, and not just one, bilateral. So bilateral enlarged kidneys. Good. So we're gonna get an ultrasound, MRI, an IV pyelograms, or CT. And what does this look like here in the picture? Oh yeah, look at that thing.
Oh, Lord.
So what is the size of the kidney normally?
This.
Like your fist, like sitting right here, right? Look at that thing, it's as big as a football. We're talking about both of them looking like that. How do you think that affects their function? Hurts, It hurts when those cysts rupture. You will see that in their urine like a smoky hematuria. Not seeing distinctive smoky hematuria, like smoky kind of grayish discoloration with blood. Okay, infection obviously is a big concern here. This is a genetic condition, can occur in infancy. That's a recessive condition. And then it can happen in adulthood, and that's actually dominant gene. It doesn't show up till like midlife. That's also distinguishing. You would see blood and urine, protein in the urine, elevated BUN and creatinine. So the biggest thing for us is hypertension control. So what kind of meds might we be giving for hypertension control? And for this little guy. ACE inhibitors, good job. ACE inhibitors. Good. And
Angiotensin two inhibitors.
good. The arms, right? Good, good. Why do we want such tight control of their blood pressure?
We just talked about how like blood pressure affects the kidneys and their kidneys aren't working.
Yeah,
right.
look at their kidney. For the love, you gotta protect what is working. So good job, like getting that blood pressure down so that it is not causing more injury. Those cysts that are there are already causing damage, right? So filtration is affected, everything is affected here. Pain management, because this can be very painful. Infection prevention is huge, because they're just fluid-filled cysts that burst. Constipation, we don't want to be increasing pressure, abdominal pressure. Monitor for renal calculi. What's renal calculi? Kidney stones, that would be horrible. Gosh, okay. So we are monitoring weight, notifying the provider for signs and symptoms of infection, dietary restrictions. What would those include? Yeah, low sodium diet. Right, so what food should these people not be eating when they go home?
Processed food.
Canned foods, anything in cans, has a lot of sodium to conserve it, right? Yes, so stay away from that. Fresh veggies, good choice. Fresh fruits, good choice. Nothing canned, no processed meats, no ham shank, no, I don't know, what else, potato chips. Okay, eventual kidney transplant or dialysis. Right question. A nurse is caring for a client who has polycystic kidney disease. Which of the following findings should the nurse expect? Hypotension. Now, get rid of that. Nice try. Nice try. Hypotension, no. Urinary retention. Confusion. Blank pain. Yeah, that's expected for sure. The other ones you're like, I'm not sure, then don't choose them. Choose the one that you're sure of. Blank pain. 27-year-old female presents to PCP complaining of frequent painful urination, fever, chills, nausea, and blank pain. What are we going on here? Hello? We have a 27-year-old presenting to the primary care provider with frequent painful urination. Good, so it could be a urinary tract infection that has now moved to the kidneys, so we call that pyelonephritis, right? Other signs and symptoms?
Okay.
Blank pain? Right there, good. Flank pain meaning like they come in like this. Ugh. Because their kidneys are hurting, that's what they're feeling. Okay, fever, chills, nausea, painful urination. Female. Why females? Short little urethras. Yeah. So we do a UA. Urine culture, blood culture, CBC, which shows increased white blood cells and increased immature neutrophils, indicating an acute infection. What is the most common organism causing UTIs? E. coli. Good job. We treat with antibiotics. What are you gonna tell me? I am your patient. You're handing me my antibiotics. Finish them.
Finish him.
Even when you start feeling better in 2 days. Because you will start feeling better. And don't save them for the next time this happens. Why are we saying that? Or something else. So resistant organisms, this is how we get resistant organisms, when people do not consume their full course. And then it adapts, so the next time we need to use Bactrim, it doesn't work. The next time we try to use Cipro, it doesn't work. There is an endpoint to that. We don't have an endless number of antibiotics. So what happens if you get a UTI that causes pyelonephritis and then causes sepsis, but it's a resistant organism?
Uh-oh.
Sepsis,
Not make it sit there.
and people die. So it is not something to take lightly. And it's usually related to just not understanding. Right? Used to be that we gave antibiotics for viral things. That was part of the problem. Now it's just people being like, oh, just save it for next time. Fluid replacement, so do we want them to limit their fluids? No, kidneys, yeah, increase your fluid intake. Pain management. Okay, so like now, okay. What's pyridium? The little medication that helps with bladder spasms. And it causes every bodily fluid to turn orange. Probably good to know that, right? Tell your patients. Be alarmed when everything turns orange. All right, what education can you give them on how to avoid UTI and pyelonephritis? You know, I love my education. What are you gonna tell me? How to prevent UTIs?
What that?
Nice.
Avoid baths if you're like, prone to UTIs. Like sitting in nice, warm, tepid water. Can't do it, can't do it. Okay, awesome.
Like,
Yes, front to back. Instead of bringing E. coli to the meatus, bring things from the meatus towards the anus. Right, front to back. Good, give me another one. Miss Lily. So front to back, no baths. Yeah, cotton underwear, breathable fabrics. Yes.
Void after sex.
Yeah, void kind of clear the path after sexual intercourse. Good.
Very lots of fluid dehydrated.
Yeah, be hydrated.
don't hold your pee.
Yeah, don't hold your pee. When you gotta pee, pee, right? Said every good nurse who works a 12-hour shift is like, oh my gosh, I've never peed this whole shift. Wrong, wrong. Pee, people. You've got to protect your kidneys. Right? Pee. And drink. You guys are good at hydrating. Drink, hydrate. What about, this could be a EVP project. Does cranberry juice help prevent UTIs? I don't know. People swear by it. Okay, look it up. Yeah.
Isn't it like a, doesn't prevent, but isn't some with antioxidants, like help?
You know, yeah, you're right, babe, you're right. It says it doesn't actually prevent it, but it makes the lining kind of acidic so that things don't grow. But then I'm like, isn't that preventing it? I don't know, but maybe not in all people, but yes, yeah, good job. Okay, so pyelonephritis, how could this happen? Wait, I thought we just had women are most at risk. What's this, men over 65?
Could be like due to urinary retention, especially prostate.
Right, as their prostate enlarges, they cannot void as easily, so then they retain that urine in there, and they're prone to infection. Good job. Chronic urinary stone, spinal cord injury could also put you at risk because either you have a suprapubic catheter in or you have an indwelling catheter. It's always going to put you at risk for infection. Congenital malformations, chronic illness, VUR, one of the pediatric conditions. And I can't remember right now. Someone would Google VUR as related to urinary. No, they don't know. Oh, sorry, Brooklyn, got it?
Basic or portal reflux.
Okay, is that when the urine just, oh yeah, that's when the urine goes from the bladder up the ureters into the kidneys and that's what's causing the kidney infection. Yeah. Yeah, so pee when you gotta pee, people. Okay, so we treat with antibiotics often. It's related to bacteria, opioids or NSAIDs, avoid medications that will tax the kidneys. And if there's abscesses present, surgical management. Okay. 74-year-old American Indian presents to the ED with complaints of right-sided flank pain, fatigue, unintended weight loss, blood in his urine. Upon palpation, a mass is felt. He has a history of tobacco use and has been in construction for 35 years. What kind of things stand out to you? Yeah,
The flank pain and the mass, and then he also has blood in his urine. That's like the triad for cancer.
good job, good job. So I would remember those things. Fatigue, not so much, that can be with other things, right? But that flank, pain, mass, and blood in the urine. Weight loss, remember, is one of those constitutional signs. If he said he was having night sweats as well, you'd be like, oh my gosh, my cancer. And then his history of tobacco use, yes. And what's the construction works issues? Asbestos or other chemicals, right? Breathing in who knows what for how many years. Yeah, just environmental toxins, exposure. So an ultrasound shows a solid mass within the cortex of the right kidney, and he is diagnosed with stage 1 renal cancer. The patient asked if he can get chemotherapy. Chemotherapy.
Is a renal cancer usually like be resistant to chemotherapy so that you're going to do surgery or like palliative radiation?
Yes, isn't that so interesting? So these things that filter all our blood are resistant to chemotherapy. We cannot use that. Yeah, so surgical intervention, radiation is what we have. Right, might mean transplant. But usually this is affecting one side, not both. Can you live with one kidney? Tell me about Wilms tumor. Wilms tumor. Is this in your reading? It's under pediatrics. Okay, so that's a clue if I'm talking about a little kid coming in with like fatigue, lack of appetite, maybe changes in urination. The kind of thing, this kind of talking about a stomach ache, like nausea. What you want to do is maybe palpate his belly. The biggest thing about Wilms tumor, if we palpate, we can spread and metastasize that tumor, which is actually a kidney tumor, around the abdomen. The biggest thing I need you to think about, anybody presents with those kind of bag-like symptoms in a little child, before you palpate, get a CT. Right? Make sure that it's not Wilms tumor. Can you imagine being the cause of metastasis on a little child? You didn't know this was Wilms tumor. And it's very vague. The symptoms could be anything. It could be like the flu. Usually not vomiting, but lack of appetite, fatigue, nausea. So make sure you're not palpating the belly. NCLEX loves to ask about the Wilms tumor. It's not that common, but you should know that dramatic effect. Okay, a nurse is caring for a client who has chronic renal disease and is receiving therapy with Epitin alpha. Which of the following laboratory results should the nurse review for an indication of a therapeutic effect of the medication? What is it? Platelet count, white blood cell count, ESR, or hematocrit. Remember what Epitin alpha is used for? And so you want to try your hand at that one?
Hematocrit.
Yes, that is correct, because Epitin alpha is Epigen, erythropoietin, the synthetic form of it, right? Yes, sometimes people take this to increase their red blood cell count to help them have greater oxygen carrying capacity to run faster, longer. Athletes will take this. Would not recommend it, but we'll take it to be able to have better oxygen carrying capacity. Good, so hematocrit, good. All right, a nurse is reviewing the ABV values of a client with chronic kidney disease. Which of the following sets of values should the nurse expect? Well, 7.30 is what? Acidosis, bicarb of 26, normal, PaCO2 of 50. Is this a respiratory or metabolic issue? Okay, so let's get rid of that one. All right. pH is 7.25. Acidosis. Okay, so we have a plethora of hydrogen ions. My bicarb is 19. PaCO2 of 30. So what is this?
Metabolic acidosis.
Metabolic acidosis. Could be. Renal related. How about 7.50? alkalosis, bicarb of 20, a little low, right? Okay, PaCO2 of 32.
Yeah.
Low. So what do we got? Respiratory alkalosis, get rid of A and C. All right, let's try D, 7.55, alkalosis, bicarb of 30. High. PaCO2 of 31. No, like, what do we call this? Metabolic alkalosis. That has a mixed picture happening there a little bit. So we can see both. We can see acidosis and alkalosis, just knowing that our kidneys are not able to remove the hydrogen ion or retain it. Same thing with bicarb. And those two things are going to be affected. All right, last one. A nurse is teaching a client who has chronic kidney disease about limiting foods that are high in potassium. Which of the following foods should the nurse instruct the client to avoid? Oh my gosh, green beans, tomatoes, asparagus, bananas, raisins. I don't know, let's guess. Okay, green beans, I'm guessing yes. I think that's high in potassium. Someone check that. Are green beans high in potassium? Thanks for Peter. Tomatoes? It says no? Oh my gosh, okay, don't worry, I'm gonna all right, tomatoes. Yes, but oh my gosh, I should have the answers, I'm so sorry, okay. What is the answer? I know bananas, that's straightforward, asparagus? I think asparagus, oh my god, don't listen to anything I'm saying. Someone look this up. Asparagus is no, green beans is no. Tomatoes? Okay, tomatoes, bananas, raisins? Yeah. Raisins are? Anything else, Sam? Or did you just Google it? Or
I just
raisins?
said raisins.
Okay, say, put in, what foods are high in potassium?
I don't know.
One thing we should mention, when people are on a low sodium diet, we tell them that they can use Mrs. Dash. Have you guys seen this?
Yes.
So it's just like herbs and such. But it is high in potassium. So if they have issues with their potassium, they can't be eating them. Okay, it's good for low sodium, but not good for high potassium. All right, so did we come to the decision tomatoes are high, bananas are high, and raisins are high? Anything else? NCLEX loves these, we should know this, to get good education. I am failing you this morning on high potassium foods. Okay, anything else? Dark leafy greens, spinach. Kale? I know.
Because
Say
family.
Oh my gosh. Okay, on Wednesday, we're gonna talk about acute kidney injury and chronic kidney injury. All right, we're gonna take a quiz. So, can you have your the little sheets?
Oh, I'm gonna go. We're just stretching and get what woozy. I'm going down. Look down. I'm looking down.
Oh,